My name is Dr Julia Crawford. I'm an Australian trained ENT surgeon, so ear, nose and throat surgeon. My expertise lies in the treatment of head and neck cancers, all cancers that affect areas within the head and neck region, but more particularly in cancers that affect the tonsil and the back of the tongue, which is called oropharyngeal cancers. So my other areas of expertise lies in the surgical treatment of obstructive sleep apnea and in snoring. I've done what's called fellowship training in both of these areas, where I've gone overseas after my initial training in ear, nose and throat and done further subspecialty training in the treatment of these disorders. So head and neck cancers, it tends to be a fairly rare cancer in that it's only about 6% of the overall cancer burden diagnosed each year in Australia. So there's only a small number of patients diagnosed with head and neck cancers each year. Those patients diagnosed with them, it tends to have a big impact on their the way that they're able to communicate and eat and drink. So traditionally, cancers were affecting the head and neck were commonly affecting people who were older, but in oropharyngeal or tonsil and base of tongue cancers, it's a much younger population who are affected, sometimes down to the age of 30 to 35. It's a really uncommon thing to see a younger group of patients diagnosed with cancer, but what we're seeing now much more is these cancers in younger groups of people. The reason that we're seeing younger people affected by oropharyngeal cancers is related to something called human papillomavirus, which is one of the newer things that fuel this type of cancer. Whereas traditionally, we would have seen cancers being caused by smoking or alcohol. Mostly when people present with an oropharyngeal or tonsil cancer, what they first notice is a lump in their neck. And often you don't have any other symptoms associated with it. So when someone's had a lump in their neck that they can feel, and it's been there for more than about 6 weeks, it's really important that this is investigated, and the first port of call would be your GP or general practitioner. The other things that can present, or the other ways that it can present, is sometimes you can get a change in the way that you swallow, where it's a little bit more difficult to swallow. Occasionally you can get a feeling like there's something stuck in your throat that you're not able to clear, or it can be associated with a pain that goes up to one ear, that's specifically just to one ear, and your eardrum looks okay when someone has a look at it. So in head and neck cancer, the use of a robot is a fairly new technology which has come to the fore over the past 10 years. The robot is really able to be used for people who have cancers that affect the tonsil and the back of the tongue. And the reason that it makes a big difference is that it's a really zoomed in view of this area, and we have wristed articulated instruments that are able to bend around corners to be able to get really good vision of structures, plus really good access into those areas to remove cancers. Snoring and obstructive sleep apnea are a disease on the same spectrum. So snoring on one end is a reverberation of tissue, whereas obstructive sleep apnea on the other end is a reverberation of tissue that's associated with pauses in your breathing during sleep that would tend to cause you to be pulled from a deep sleep into a light sleep, and so changes the refreshing nature of your sleep. So in terms of what would generally cause someone to snore or have obstructive sleep apnea, it relates both to people's body habitus, so potentially if they're carrying a little bit of excess weight, but also to anatomical changes, like if they have big tonsils at the back of their throat or they have a big back of the tongue, in addition to whether the whole muscular structure of their throat tends to be more collapsible than other people's. Even though a lot of people think that snoring tends to come from their nose, it's actually not usually the place that causes the main noise of snoring or sleep apnea. So nasal congestion and obstruction can contribute to snoring, but it generally comes because of collapse of other soft tissue in the upper airway, and that collapse is made worse by having nasal obstruction. So for an average patient who has snoring or obstructive sleep apnea, it's usually a huge burden in their lives. From a snoring end of the spectrum, it's usually a burden for their bed partner because they find it really difficult to fall asleep or stay asleep, and so it can potentially be quite disruptive in people's relationships. On the other end of the spectrum, if someone has obstructive sleep apnea, it's usually a burden more for the patient rather than for their bed partner, in that it potentially has a risk to their long-term health or to your long-term health. So when we're looking at obstructive sleep apnea, you can break it down into mild, moderate and severe sleep apnea. And when you're looking at severe sleep apnea, which is where you're having 30 episodes of pausing in your breathing during sleep, that can affect your long-term heart and brain outcomes. And by that I'm talking about an increased risk of arrhythmias, where you've got an abnormal rhythm of your heart, increased risk of heart attack, and from a brain perspective, an increased risk of stroke or dementia. So untreated sleep apnea can also affect the way that you feel during the day. Sometimes, even though you've slept for 7 to 8 hours at a time, you can wake up feeling unrefreshed, like your head is a bit fuzzy or foggy, and wake up with a headache in the morning that takes a couple of hours to settle down. So when we're looking at the treatment of severe sleep apnea or sleep apnea in general, the most common thing that would be prescribed would be something called CPAP or continuous positive airway pressure. But this isn't the right fit for everyone, and for some people they're just unable to tolerate the use of CPAP because they feel really claustrophobic, or they're not able to tolerate having the feeling of air blowing against their face at night. If that's the case, then we need to potentially look into other treatment options that can help people. Some of those can be device related, so something called a mandibular advancement splint, which helps to stabilise the airway. But then we can also potentially look into whether surgery is an option for treatment. Those surgical options vary depending on the patient and really vary depending on what the anatomy of each patient is like. And surgery won't be the right approach for everyone, but it's something that needs to be examined to understand whether it can be an option. The way that we can work out whether you're snoring or whether there's obstructive sleep apnea involved is with something called a polysomnogram, which is a sleep study. So a sleep study is usually ordered by someone called a sleep physician or a sleep doctor. And there's two types of sleep studies that you can have done. One is an in-lab sleep study and the other is a home sleep study. On a sleep study, you need about 4 hours of sleep to be able to determine if you have simple snoring or obstructive sleep apnea. The most common people who are going to be surgical candidates for obstructive sleep apnea are people who do not have a large amount of excess weight and potentially have really big tonsils as well, so that there's a chance that we can make things better from a surgical approach. So robotic surgery is appropriate for sleep apnea and snoring only in a fairly limited number of patients, and it's really for patients who have a big back of the tongue which is obstructing their airway during sleep. The only way that we can know that is to be examined with something called a flexible laryngoscopy, where we put a little camera in through the nose to turn down and look at the back of the tongue. And in patients who have really big tissue obstructing the back of their tongue, that's when surgery with a robot is appropriate. So in the younger population, one of the commonest causes of recurrent sore throats tends to be what's called recurrent tonsillitis. Tonsillitis is different to pharyngitis. Pharyngitis is where the whole back of the throat is red and inflamed, whereas tonsillitis is where the tonsils themselves, which sit at the back of the throat but in one particular area of the back of the throat, get red, inflamed and tend to get a whole lot of pus over the top of them. If someone has pharyngitis, then we're not able to remove the source of the problem because we're not able to take out the whole throat. But if someone is getting recurrent tonsillitis, then by removing the tonsils, we're able to remove the source of the recurrent infection and decrease the likelihood that someone will get those infections ongoing into the future. When someone gets tonsillitis, they typically start by just feeling generally run down for the first 24 hours or so, and then subsequently start to develop increasing pain on swallowing. They often have difficulty swallowing certain types of food, sometimes all foods, and they may get to the point where they're only able to swallow liquids. The other thing that can sometimes happen is they can get complain of an ear problem or ear ache, because the pain from the back of the throat is referred up to the ear. So one of the complications of recurrent tonsillitis can be the development of something called a peritonsillar abscess, or quinsy as it's more commonly known, where you get pus forming in between the tonsil and the muscular structure that sits underneath it. If that happens, it's often at the end of someone having had a bout of tonsillitis. They would usually then get increasing throat pain localised to one side, have difficulty opening their mouth, may notice a change in the quality of their voice, and sometimes can get to the point they're not even able to swallow their own saliva. When someone's had recurrent episodes of tonsillitis that is affecting their ability to be able to work or go to school, it's important to consider whether a tonsillectomy is an appropriate treatment. We would typically look at a number of times that a patient is having tonsillitis in a year, and if there's 6 to 7 episodes in 1 year, 5 episodes per year over 2 years, or 3 to 4 episodes per year over 3 years, that's an indication from an infective point of view to have a tonsillectomy performed. So other potential indications for having your tonsils out are if you've had recurrent episodes of quinsy or peritonsillar abscess. So that means if you've had 2 or more episodes of quinsy, that would be a reason for having your tonsils taken out. So one of the other reasons that you might consider having your tonsils removed is if you're getting recurrent tonsil stones. So tonsil stones are little bits of food debris that tend to get stuck in the crypts of the tonsil. The tonsil's made up of these cliffs and valleys, and these valleys are where little bits of food can get trapped. And typically there's a bacteria that sits in those valleys called actinomyces that can react with the food debris to create these little bits of white material that look like stones. That can subsequently cause not just the tonsil stones themselves, where you can feel them in the back of your throat, but also halitosis or bad breath. So that's one of the other non-infective reasons that you would think about removing tonsils. So when you're looking at an operation to remove the tonsil or the back of the tongue, all of the surgical robot allows us to do all of this just by going through the oral cavity or the mouth. We don't have to make cuts on the outside of the face or through the jaw to be able to get through to the back of the throat to remove a cancer. What that means is that a patient can start eating and drinking from the day after the surgery, and it typically means that they're back to fairly normal function within about a month, which is a significant improvement from what we used to see with open type surgical approaches.